third conf lecture. Today we are going to talk about your future, because you are the future doctors and nurses and so on. And so we can try to imagine from the transition which you are going to examine, which will be your future as doctors, which one will be your patients of the future. So we are talking about, we will begin. Today we have an exceptional, outstanding guest, who is Professor Doug Marinenburg, and then I will introduce her. And so these are two graduation theses. The first one in the left is my thesis. As you can see from the year, it was 1971. And the object of my thesis was coronary care units. It was the time when we were very busy in trying to contrast myocardial infarction. We had the mind towards acute illnesses. And so we won our fight against myocardial infarction because the mortality because of this disease has decreased a lot. And this has contributed to create a new population of patients. And on the right, you will see the thesis of my son Paolo. It was 2018, and as you can see from the title, he's speaking about immunosuppression in blood cancer. So it is something completely new, because the cancer of the bladder is something which is chronic. So just to see the subjects of two theses, which are about 50 years distance one from another, are quite different and reflect the way medicine is changing. So this is what's happening. You see the age pyramids. As it is at the beginning of this century, and what will be in 30 years. So we will see that in 30 years we will have we will have a population whose head. Okay. No, per il pointer. Okay. We will have a population which will be mainly displaced towards over 60 years. So we will have a very different population from what I was used to see when I was young as you are. So something has changed and is going to change. Changing the population and the mid-age of the population changes also the diseases. So this is life expectancy. If you see in 1985, you were not yet born, the life expectancy for a man was 72 years. Now it is more than 80 years. So, and when we had the lucky to reach 95 years, this is 40 years ago, you had the right to expect 2 years more of living. Now, this has changed to 2.6. So, life expectancy is radically changed in the last 50 years. So, a bit of history for you. These are 3 mushrooms who have changed our story. The first one is the Penicillium chrysogenum. It was the Penicillium chrysogenus, the mushroom of the penicillin. So when in 1939 antibiotics were invented, were discovered, this has brought about 10 years of increase of life expectancy. Another important mushroom is this one, which is Penicillium citrinum, is the mushroom who is in the rhizomes, and this is the first statin who has been discovered. Statin are drugs against cholesterol. So this is a big victory against atherosclerosis. The third one, well, I hope we will never see this kind of mushroom. Okay, so let's try. I am a cardiologist, so from my point of view, cardiology has made a lot. It has been the first responsible of the increase in life expectancy, but also oncology, pneumology, and other specialties have contributed to create this new population, which is up to you to take care of. In 1958, pacemaker was invented, and today we have a simple instrument which weighs no more than 30 grams. The defibrillator, then angioplasty in 1977, the transaortic valvular implantation at the beginning of this century, the mitral substitution by means of transcatheter was invented in 10 years ago. And then in cardiac surgery, in 1953, the first open heart operation, and then we have first heart valve replacement in 1960, and 1968, the first aortocoronary bypass, and 69, the first cardiac transplant, and drugs. Drugs have changed radically our life expectancy against hypertension, antihypertensive, statins against cholesterol, and thrombolytic. And so this was the naive sentence written in my thesis. Maybe in using the computer could solve many problems. I was saying 50 years ago. Okay. The next venture revolution, we have been talking about artificial intelligence in the first conf lecture. We will hear Dr. Marinenburg this evening to speak about chronicity and the era of chronicity. What is chronicity? Okay, look at this clinical case. This is one of my patients. Well, his history began in 1992. He was 40 years. He had two-stage angioplasty. He had 63 years. He had without did the demonstration of patency of the stents he had implanted. And he had a defibrillator implanted when he was 68. At 70 years, he had new angioplasty. In 71, he had a valve repair of the mitral valve. 71 years, chronic atrial fibrillation, he had ablation. And 75 years, he's doing well with new drugs against heart failure. So look at this other history. Well, if you imagine just 50 years ago or 40 years ago, this could not have happened just because we had not such procedures and drugs. And this case is quite interesting. When he was 50 years, he had the revascularization of the femoral artery. He had coronary bypass, and then 77 years pacemaker implantation, 81 prostatectomy, 82 left hip prosthesis, 86 endoprosthesis of aneurysm of subabdominal aorta, 86, 91 he had a peaceful chronic heart failure, and then he died because of cancer of the bladder. So you can see these are very long stories, and you can imagine that to assist this kind of patients requires a new philosophy, a new methodology, different from what I was used to see. So if we can imagine our life like bars, no? You see that our life is green until a certain moment. We are in very good conditions. And then from 70 years, 65 years, something begins to change. We go to have our quality of life is conditioned by chronic diseases. We can imagine hypertension, we can imagine myocardial infarction, we can imagine cancer. We are able to improve, to increase life expectancy. But if we don't improve the quality of life, if we don't prevent many diseases, we run the risk of increasing the time of the sufferances of the patients. So, well, I imagine that Dr. Marinenburg will talk about this, so I don't want to take any more time to her. And so it is far from over. And okay, I want to introduce you the Dr. Doug Marinenburg. She has written a splendid book about chronicity. And well, I will invite her. I invite her to tell her story and the story of chronicity. Prego, Dagmar. Un applauso per Dagmar. vuoi parlare da lì o da qui?
Sì,
Come
sì,
pre-
da lì, penso che... Okay, good afternoon, everybody. So it's afternoon, it's hot outside, and I will talk about chronicity. And chronicity normally makes a little bit tired, no, because it's a lung disease, it's not an immediate solution, it's just difficult, no? And I would like to get you passionate to chronicity, because I think at your age and your future in medicine will be to cure a lot of chronicity. And I would like to start with a video which I saw on YouTube, and I liked it very much because everybody thinks chronicity is about the changing pattern of aging, and we have a lot of people with multimorbidity, and we have a lot of people with many problems after 65. But chronicity is also the triumph of medicine. I would like to say chronicity means that we have resolved problems. Like Professor Boccanelli showed you before, because of the many progresses done in cardiology, many people who would have died about 20, 30 years ago, nowadays they will go on living with their chronicity. But it's not only a problem of middle-aged, cardiopathic, obese, older people. No, it's also a problem of young people. It's especially a problem also of newborn, of premature newborn, who will bring with them a lot of chronic problems which will accompany for their whole lives. So the first video I would like to show you is the story of Sita. And she will tell you, I think you can all follow it. And can we please have the first video? It's about 12 minutes, more or less. And she will tell you from where she's suffering. She has more or less your age. This also to say that everybody of you can enter, or is just entered, or is entered for a long time in chronicity. I don't want to ask you, but I suppose that somebody will suffer from diabetes, and somebody has to do some injections, somebody will have had some injuries and they have chronic problems, or somebody has a metabolic problem, also in your age. So chronicity and chronic problems, it's not only a problem of older age. So Sita will tell you. Just stop it. You can stop it just a medical chronic. So she makes the introduction. A chronic disease is a disease which lasts more than 3 months and which it doesn't have. A disease which it has more than 3 months and which doesn't have a cure with medicine or operation or vaccination. So that's her introduction. So.
Intractable seizures. we got to the crosswalk, and as we were crossing, boom! I had a seizure and fell flat on my face. Now, I had taught this person about the appropriate seizure first aid. The first thing I told him, be calm. So when I came out of the seizure, 2 minutes later, I pulled myself up, back on my feet. I'm here. It's okay. He was calm, but he was so full of fear. I could feel it. So I was getting my head back together, and he said to me, well, I don't see a third date happening here. Excuse me? I would have expected you to at least text me that after we said goodbye. That would have been a little bit more tactful. So in addition to acceptance of other people, you need to come to terms with your own chronic illness. Acceptance is the big job of the chronically ill. No, it doesn't happen overnight. It can take years and even a lifetime. Acceptance brings up ideas such as, what does this mean for me? Will I be able to find a partner? Will I have kids? Will I be able to raise these kids? Will I find a job or live in constant poverty? These thoughts can be so overwhelming, and it takes a lot out of you. Also, when we are children, we are told, dream big. What do you want to do when you're an adult? I have known that I have wanted to be a social worker since the age of 10. I don't know about you, but for me that's a long time. I'm a registered social worker, but I don't know if I will be able to do what I want to do in my line of practice. I also have a good friend, Vanessa, who used to be a competitive dancer. Then she was struck with arthritis. She had to completely alter her life path because of a diagnosis that had no cure. How would you feel if you had to give up your dream? So I've thrown a lot at you with regards to chronic illness and what it's like to live with one and all the things that you have to go through. And you might be a little bit overwhelmed at this point. But don't worry, that's why I'm here. So my 3-point plan is this. Super easy. You can follow it. First of all, accept that there is no such thing as a norm. Everybody is different with regards to mental health, ability, and well-being. Accept that and act accordingly. Also, you may be struck down with the chronic illness at some point in your life too. My second plan to action is to have empathy. You have no idea what people are going through on a day-to-day basis. If you do, though,
Did you like this? Was it useful for you? What do you think? Yeah, no? We learn a lot about seizures, but we also learn something about empathy, which is very important when you are treating chronic ill patient, because you can decide in your professional life to be a technician as a doctor, who is the one who resolves problem, or you can be an empathetic doctor who resolves problem, but who also gives something of his feelings and of his heart to the patients. So after this introduction, I would like to give you, I will just come here. I would like to give you some informations about chronicity. I will then show you another video which is about amyotrophic lateral sclerosis. I don't know if you have an idea what kind of disease it is, and then we will, at the end, we will see another video which is much more open-minded, also out of what is illness and disease and so on. Okay. So, this is just, I will not read everything, but this is just what we connect with chronicity, and it's not, in general, it's not positive, no? It's something between boring and settled, habitual, and something which we don't like so much. The definition, that is what Sita said at the beginning, is that it is a disease which lasts more than 3 months, and we don't have a therapy or vaccination for it. And with this condition, we know that about 40 million Americans are suffering from chronic conditions or diseases. And in these 40 millions, in America, I think at the moment there are about 30 million diabetic patients or patients with glucose intolerance. A very important journalist of the New York Times, if you can read her, she has always something interesting to say, is Jane Ellen Brody, and she defined the becoming chronic in saying it's healthy in a falling apart sort of way. So it's something that we get in pieces, and that everyone you have a piece lacking. You have to invent yourself in a new way. For example, somebody of you does know kintsugi. Kintsugi, somebody knows it? It's an ancient Japanese art to repair porcelain, is it porcelain? Yeah, to make together pieces of something which has broken, and you make it together. And we nowadays, we use it in workshops for people with cancer who have to get used to a new kind of life. No, this is, and therefore this healthy in a falling apart sort of way. I find it's very, very useful as an image. The definition of health, you know that in 48 it was said it's a complete physical, mental, and social wellness, which is really not possible. In 2011, the British Medical Journal said is health a state or an ability towards a dynamic concept of health. So we can have a lot of chronic conditions and feel healthy anyway. No, so this is a little bit changing. The fact sheet, this you can read. It's the one of 2018, and there's not a new one. And you see it kills chronic conditions kill 41 million people each year. And 15 millions are people between the age of 30 and 69. not the ones Professor Boccanelli showed before, who have all the possibilities, for example, of medical progresses and cardiac surgery and stents and new medicines and so on. But in most parts of the world, we don't have all these things. So we have a lot of premature deaths. And you know that tobacco use, physical inactivity, the harmful use of alcohol, unhealthy diets and other drugs are responsible for this. It's difficult to think chronic because we were very used to heroic medicine. One who started the heroic medicine, who was Robert Heinrich Hermann Koch, who saw for the first time the tuberculosis bacterium. And from this point on, there were a lot of progresses. It was possible to perform anesthesia. Without anesthesia, you cannot operate anybody. So they did it before, but it was quite difficult, and many of them died because of the too much stress. So all this started with anesthesia. Chronic and acute, are these two different pathways, or do they sometimes go together? So I once again come back to the point that we are still, and especially our generation, is very much in the prison of acute thinking. We don't think chronic enough, and we have these images. Sorry, but for me it's very, very important that you listen, because if not I cannot concentrate, because English, it's not my first language, sorry. And so we have a lot of images of the TV shows, of films, of emergency rooms. We have ER, which was one of the first. I don't know, do you still see ER? Do you know the TV? No, it's too old, no? Grey's Anatomy? Yes, okay. Grey's Anatomy, it's a little bit, and you know, in Grey's Anatomy, rarely you have chronic conditions. You sometimes have some problem with the chronic conditioned patients, but normally they are surgeons and they are resolving problems, and I think we don't have a TV show. There was one American, it didn't have a great success, which was in a nursing home, but normally it's emergency room, it's surgery, anesthesia, and all these problems. And this what the TV shows show us, and the film shows, it goes in our subconscious, no? Medicine is something which has to resolve our problems immediately. A lecture which is very much recommended, it's from 1978 by Samuel Shem. It's an American doctor who became a psychiatrist, and he describes his years in the internship. You know that the Americans have this time of internship, which is very, very very hard, and if you read this, and you can see that so many things are not changed in the emergency rooms. And one thing he said, for example, it's this Goma. He called the people Goma, which were the chronic people, and he said they are Gomas because they have to go out of my emergency room. Because a Goma doesn't have to be here because it has a chronic problem. Why do you bring here? And you know how many people in the emergency rooms have this problem? They bring their very old mother or father to the emergency room, perhaps because she has diarrhea and she needs some fluid therapy and so on. And the nurses say, why do you bring her here? This is here for emergencies, for real emergencies. And then we go to the big problem of organization of healthcare. But it's very interesting to read this book. breaking the rules. These are two. Did you see these ones? Perhaps they are newer. It's The Resident, which is quite interesting. There's somebody who is a little bit passionate for TV shows. And then is New Amsterdam. These are doctors. They are breaking the rules. And this is, therefore, is it very interesting. They are breaking the rules of the organization. So I would like to go on to talk a little bit about the history of chronicity and what changed and the places, the difficulties to be, but this was very, very well explained by Sita, and the difficulty to cure in chronic settings and possible solutions. How can we think in another way? So once, the typical chronic place was a sanatorium of Davos, which is in Switzerland. And there, the people with TB, they have been there for 1 year, 2 years, 3 years, somebody also 5, 6 years. They just had to eat a lot, and they had to have fresh air, and sometimes they do the pneumothorax to make collapse the sick lung, but that was it. We didn't have much more. These are the places. In the afternoon, everybody outside to take the fresh air, and they hope to get better with this. This was the time where Thomas Mann, one of the most famous German writers, wrote The Magic Mountain, which is all about a sanatorium in Davos. And if you are interested in literature, it's a must. But what happened then? Tuberculosis became a communicable disease. You know, Robert Koch found the bacterium, we found the antibiotics, and it was not anymore a chronic disease, but a communicable and healable disease. So it get completely out, and this changed the organization of healthcare very much. You know, if somebody has been to the Forlanini Hospital, it was the biggest hospital for tuberculosis care in Europe. The Japanese came here to Rome to see how well the Forlanini Hospital was organized, because it was very good with the food, with elevators for food, and with a very big garden with orange trees, and it was
the theater.
And the theater, and yes, it was really a very nice place, and now it's in ruin completely. We cannot use it anymore. Most of these sanatoriums, they became rehabilitation clinics or other kinds of hospitals. Now, in 2022, we should try to cure all the chronic patients at home and with ambulatory facilities, to avoid and to prevent the visits in the emergency room where they become the gomas, and this we would like to avoid. To think with the paradigm of acute medicine in chronic settings is harmful. Acute medicine acts when there's an acute event. In chronic settings, you should not wait, but prevent. You should be proactive, which is a completely different approach to medicine. If not, you will find chronic patients or terminally ill cancer patients in a crowded emergency room where many people are angry and frustrated. And every 2-3 months, you can read something of this in the newspaper. My father died in the emergency room in the terminally ill patient in terrible conditions in the emergency room. But we have to ask, why did he get there? Why nobody organized everything before this was necessary? No? So think chronic and be proactive. And what I said at the beginning, chronic, it's not only the privilege of old age, it's also something which is happening in newborns. Newborns, they go out of the hospital with oxygen, with a lot of tubes and so on. This is also a chronic condition which sometimes lasts for a lifetime. They have problems also with to see, they have problems to hear enough, and it may be very hard to be a premature born. it is difficult to be a person with a chronic health problem. Also, this Sita, she told us. And the difficulty is to be resilient and to be able to cope and maintain and restore one's own integrity, and to have a new sense of equilibrium and sense of well-being in spite of the chronic condition. And this is difficult because you have to adapt and to self-manage. Sure.
Is there anybody of you who is planning to become a general practitioner?
Wow.
When you think about your future, how many of you would like to work in a hospital? Raise the hand. I think most of you. Don't be shy. Okay, no, we need this information. Okay, and nobody would like to become a general practitioner. You are all going to work in emergency rooms and in. How many of you want to become a surgeon? Mm-hmm. And now, how many of you are planning to become a neurologist? Okay, so as you see, Dagmar, nobody wants to work aside a chronic person. No, because I think that Dagmar said something which is very true. We have an image of the doctor who is a person who solves acute problems. So your mind is still that one. But as we have seen, your future is to fight against chronic diseases. So you will have patients to take care of during their life. So it is quite different than working in a hospital. So I think that patients will need you outside of the hospital very often.
But I think it's also okay that at your age everybody wants to stay in the hospital. We stayed in a hospital for a lifetime, no? But also in the hospital you can meet a lot of chronicity, and also surgeons have to fight with chronicity because, for example, an 85-year-old man with a colon cancer, can you operate him? He has a lot of cardiac problems. He has a diabetes, and will you operate him? Will you talk to him about the operation? You have to make it together with all the other conditions he's suffering from, and then you can operate. If not, you can also finish in prison, no? Because you have to calculate very well your risk if you will just see it from this point of view. Anyway, this is another big theme. Chronic diseases put us in front of existentially important questions. Because if I can decide and participate in decision-making only if I can accept my chronicity and if I'm ready to face mortality. And this I will show you with the example of amyotrophic lateral sclerosis. If I don't know that I'm suffering from this kind of progressive disease, I cannot make decisions, no? And this only in the last 10, 20 years in Italy, the things are changing, that also for cancer patients, everybody has to know his diagnosis, and we have to talk to the people, to the patients, and not only to the family. So there's a lot of implication in this. So this is now about the amyotrophic lateral sclerosis, which fortunately is a rare disease. It's 1 or 2 about 100,000 of people. But I took this because it's a kind of progressive neurologic disease which puts you in front of a lot of decisions. At the beginning, you know, it's a disease of the motor neuron, and it starts sometimes that you only cannot move an arm or a leg, and then it goes progressively on until you cannot speak anymore, you cannot swallow anymore, and you cannot breathe anymore. So at the beginning, they normally fall 1 or 2 times, and you find them in the emergency room, and they have a leg broken, and nobody makes the diagnosis. So will you accept to use a walker even if you are 30 years old? Will you accept to be in a wheelchair? And then sometimes only months after this, you have a problem with swallowing, and what you are swallowing is going directly into your lung, and you will have pneumonia. So you will have to decide, do I take a tube, a PEG, gastrectomy tube, and then they cannot speak anymore. Sometimes one comes before the other, and so they have to communicate with the computer, focusing only with their eyes, the words they can put together, and then speaking with the voice of somebody else. And of this you had, in the last time somebody told you about a software, which is this. And then the respiration, which was my field of action in the hospital, because you have, at the beginning, you have non-invasive mechanical ventilation with the mask, and then at a certain point when you can not have any more your secretions, then you have to decide if you get tracheotomy. If you don't want the tracheotomy, you can decide for palliative care. This means that you have not the tracheotomy, that you will be accompanied dying on respiratory failure, which is very, very hard to cope. No, adesso sì, sì, l'ho accennato adesso. Yes, sure. Perché adesso ho questo, poi venire con questo.
Non c'è voce. Vai sul podio. Sul podio.
I have found very interesting your attitude to be in the future, to see you in the future as surgeons, or not general practitioners. Anyway, it's very interesting because there is an ethical problem that I think we have to underline. You have to see something inside yourself, which is your dream, to live forever, for example, or why you don't, because this is a course of moral philosophy. Then we have to discuss some topic related to, of course, ethical problems. But my question for you is, you don't have to answer me immediately, but probably after the discussion with Professor Marinenburg, Professor Boccanelli. Please try to see inside yourself which is your dream. If your dream is to live forever, if your dream is to live forever, not forever, but for a long time in good health without any kind of problem, and then this is impossible. This is strange at the beginning of the Faculty of Medicine to think not to be a general practitioner, because if you want a general practitioner is the coordinator. It's not a second role in medicine, but it's the coordinator of many specialists. Then you have to make the reflection from the ethical point of view on your answers. Okay? Thanks.
Okay, this now it was a very good comment, because it's especially about how do you want to live if you have a chronic progressive disease. And this is the story of a young man who has amyotrophic lateral sclerosis, and it's just, I think it's 3 minutes. it's 3 minutes, but look how he is living. And he posted this video because he said it's a video of positive thinking. You have a very, very big chance we didn't have in our youth. You can see every kind of disease, chronic or not chronic, in the internet. You can go into the houses of amyotrophic lateral sclerosis patients. You can go into the houses of patients with seizures or asthma or diabetes. And you can, if you are interested, but you have to be interested. If you are interested, you can see everything. And you can see how people are living with their diseases. And we didn't have these opportunities. We didn't have somebody who posted his disease from the beginning at the end. You can have videos of people who decided to die from amyotrophic lateral sclerosis, and you can see how they did it, but you have to look for them. Okay, let's see this. This is how. I just stop a minute. You see here, he has a non-invasive respirator. He has a mask here, and there is the air coming in, and his wife is waking him up in the morning. He is so an advanced stage of amyotrophic lateral sclerosis. He is paralyzed. He cannot breathe anymore on his own, only for some minutes, and he cannot eat anymore. And you will see how he is living.
It might be hard to believe, but in my head, my daily life seems just like every other Tom, Dick, and Harry. I don't open my eyes in the morning and say, damn you ALS. That would be a waste of time and energy. I get up every day with the intention to be as productive as possible. Well, at least after I have some coffee, I feel that way. It's been over 6 years since my body started to crumble from the outside in, but my mindset has always remained the same. I will not let this disease define me. So, I have machines to help me breathe and cough, and I eat through a tube and type with my eyes. Good morning. To me, that's my normal, my life. If you're living life with conviction, faith, and an open heart, I promise you two are going to hit rough waters at some point. It's inevitable. That's the time where you look around and hope you've got the right people in your boat. Don't, in fact, put my pants on just like the next guy. I've always tended to do things my way. I guess it's that uniqueness that I hope might make a difference in this fight. This is an ugly, tenacious disease. The only way we stand a chance against it is with unwavering determination and teamwork.
Has anybody of you known patients with ALS? Yeah? Somebody? No? Yeah. Okay. Okay. Do you want to talk about it?
He's just the father of one of my friends.
Okay. So it was hard to...
He's starting to have problems now.
Yeah, it's that nowadays I worked in a day hospital, and there were and it was my specialty to cure the people with respiratory failure and neuromuscular diseases, and most of them were ALS patients, and we had to do this way together with them. No, every time they came to me, every 2 months, every 3 months, and there was something changing, and we had to decide what do you want to do, and it's extremely difficult. You see this patient here, he has a young woman, he has the family around, he has all the facilities, he has what you can desire to have, but not everybody has this. Not everybody. There are also people of 70 years old, they have ALS, and they are widows, and they don't have anybody. And what will they do? Because you need another person who dedicates their life completely to you. And these are so difficult decisions in chronic settings, because we had people who decided for tracheotomy, and they went on for 15 and 20 years on the ventilator. So it's not a decision, oh, tomorrow, then it's just for some months. No, you have to decide for 15 or 20 years on a ventilator, completely paralyzed in your leg. And also the story with the voice, it's very nice until you can move your eyes. But then there comes the state in the disease that you cannot move your eyes anymore. And then you are completely in this state we call the locked in. No, you understand everything, but you cannot communicate. So this is one of the yes.
Facciamoglielo vedere quello, perché hanno visto il Trombetti cosa può fare.
No, he likes so much.
No. No, how many of you were in the conference on artificial intelligence? Okay, many of you. So I want just to show you what Marco Trombetti, the guy who was here with NASA T-shirt, has invented in ALS to give back the voice to the ALS patient. Possiamo sì.
At the moment, no, this is very interesting, because you can choose your voice and so on. The problems I had often with patients is that a male patient, a man, had his new computer from the National Health Service, but the computer talked as a woman. No? And it was difficult to change the software. So something like this here would be wonderful, no? It's mute.
Before the video, another comment related to what Professor Marinenburg said. From an ethical point of view, please, do you think that the problem is just a problem of software, is just a technical problem, or do you think that to decide to live is something more? Because you can solve a lot of problems, okay? You can have a special software to talk. You can talk with your eyes, by your eyes, because you have a special machine, a special computer. You can do a lot of things, but the choice, and then we discuss on it because it's important. The choice to live or not to live, it's your choice. And then this is the support you need to give your patients, okay? Because your patients, when you have a patient with ALS, you can't explain your point of view, but you have to follow the patient and to explain him what is probably the best pathway, but without canceling all the problems, okay? Because sometimes now we are very able to cancel everything, to transform everything in a technical problem. When we have solved the technical problem, we have solved all. No. It's not like this. Please take in consideration that this is a part, the technical solution is a part of a bigger problem.
Non c'è niente
presentato per una specie di esperimento.
Mi hanno detto che avrei dovuto solo parlare.
Quindi ho detto, perché no? Abbiamo chiesto a 5 persone di raccontarsi davanti a un microfono, registrando la propria voce.
Ciao. Ciao.
Vengo da Procida, che è una piccola isola vicino a Napoli. Vengo da Cirie, un paese vicino a Torino.
Sì, tendenzialmente mi fermo.
Sì, credo che mi fermerei, non riuscirei a lasciarlo sotto la pioggia. Gli dico che gli voglio bene e lo abbraccio.
Poi abbiamo chiesto a tutti di riascoltarsi.
Mi mette a disagio la mia voce.
La possiamo rifare? Suona completamente diverso da come ero abituato a sentire. Credevo di conoscerla, invece
Chi era quella in cuffia?
è molto cavernosa, non mi piace proprio.
È stridula la mia voce. Se potessi la regalerei a qualcun altro.
E se si potesse donarle davvero?
Ciao.
La riconosci? È proprio la tua voce.
Grazie per avermela donata. Adesso
È anche un po' mia.
parlare,
È la cosa più naturale del mondo.
ma non perché ha fatto da sola.
Ora,
Grazie a te. Posso farlo di nuovo.
con una voce vera,
Umana.
nostra,
Quindi,
vorrei chiederti
come ti fa sentire?
la tua voce.
Adesso?
Quando la doni a chi ne ha bisogno, la tua voce suona più bella. Vai su voiceforpurpose.com e dona la tua voce.
No, so che they were interested because Marco Trombetti already had spoken about this invention they made. Marco Trombetti is the inventor of Google Translator, so this is the follow-up of his job. So now he's doing this for ALS patients.
No, this is interesting, but it's only a little part of the ALS problem because it's not a technical problem. And the part the ALS patients can communicate with the computer is a limited time. No, because there it seems it's until the end of their life they cannot anymore, because if you stop some time after 2 years, 3 years, 10 years, it's very different to be not able to move your eyes anymore. You cannot communicate with the computer. But there are always more sophisticated softwares, and somebody's only going with the pupils, and then it's a work in progress. But what la professoressa said before, it's a very huge, it's an existential problem. Can I have my slides again? What I said before, what Atul Gawande said, it's an existential problem. It's how much life do you want in your life, and how do you want this life? No, would you like to comment?
Hello.
Hello.
Well, I think that
No.
Hello, my name is Alberto.
Okay.
Nice to meet you. I think that sometimes we think that it's hard, or we have to be strong to face death, but sometimes it can be harder to face life when you think that your life is meaningless. And I think that it's, of course, thinking as a doctor, we may think that it's not correct that a patient asks us to help him or her to die, but thinking as a patient, it's really hard to accept that other people can choose if your life, if you are able to keep on living. I don't know if I can.
Yeah, exactly. That's the point. That's why Atul Gawande said this. Can I accept my chronicity? And am I ready to face mortality? No, that's the very, very big question. And as physicians, we have to be We don't have to be friends. We have to accompany them. And we have to search to find the right decision for every person without judging them. Without judging them. And this is very difficult. For me personally, I would never go on a ventilator. But this is my personal opinion. But I had a pharmacist. She was 79 years old. She had nobody. No, not a husband, not nobody. And she wanted to live. And we did the tracheotomy. And the national health system in Italy covered everything at home. They did everything. But sometimes we also have to say that in a certain part of Rome, the National Health Service doesn't cover. And can you say this before a tracheotomy? It's extremely difficult because then sometimes they are in the hospital, in the intensive, I was in a sub-intensive respiratory care units. They are there for months and months and months because the National Health Service is not prepared because they have already 2 or 3 patients like this and they don't have the nurses to send at home for 24 hours for these kind of patients. No, so the decisions are extremely difficult. Extremely difficult, and some people. I had an older lady, about 80 years old, and every time she came to the day hospital, I said, "What will we do? Would you like the tracheostomy? Will you go on the ventilator?" No, I don't need the ventilator. No. Let's see further. And she didn't want to talk about it. And there came the day she came into the hospital because she didn't breathe anymore. And we put her on the ventilator, but in a non-invasive way with the mask, and she went on, but it didn't function, so she had to decide for tracheostomy. And she always said, tomorrow. And she had 2 children, two daughters, and she had grandchildren. And a certain day, she told us, only to us physicians and not to her daughters, that I will not get tracheostomy. And she chose to be accompanied to have the palliative care. And we took her off the ventilator because she decided to, or we gave her a little bit of ventilator so that just that she could breathe. And she had morphine, and she slept away. And the daughters, they came also after years to us to say hello. And because they really thought they had a mother, she was a hero, because she didn't want that the daughters had her whole life around the mother on a ventilator. And this was a really heroic decision. And I had some people like this, but not most decide to be on the ventilator. And what you have to do in the real sense, what today is always more difficult because it seems to be only a signature, you have to do a really informed consent. And informed means that you have to say everything. And this is very, very hard. Because if you are in a mood that today it's difficult and you say just, and then you will breathe again, and that's right. But you have also to say that you have to breathe like this for 10 years. That you may have pneumonia, that the ventilator can be stuck away, and that there's nobody around, and that you are gasping like this. You have to tell everything and to hear to all the questions the patients have to tell you. So, but let's go back, because this would be a whole lecture about the ethical decisions within the end of life of this progressive neurological diseases. And it's not only ALS. In ALS, it's all very concentrated in a few months to have all these decisions. But nowadays, also dementia patients have the question if they make a tube in the stomach, because they do it today. And they go on and on and on. So also the advanced decision making should be much more reinforced. But this is also another theme. So let's go on with our chronicity. So these were all the decisions he had to do, and we go back to this dilemma, because dreaming of acute medicine in chronic settings, and therefore I'm very happy to talk with you, because you are dreaming of the acute medicine. And this is right that you are doing this. And you have to go to the hospitals and you have to work there, but you have also to remember that there are chronic settings. And if you want to make the big cardiac surgeon and you are in just a normal ER, you will be frustrated. And frustration, what will it lead? It will lead to burnout. And we will become anxious, you will become depressed. We know that many doctors make an abuse of alcohol. We know that many doctors are drug abusers because of these tensions they have to live. And this is one of the problems. Because if you go in medicine, you have to face also chronicity. You have to face all these kinds of problems. You cannot only wait only for the 30-year-old man and he has a cardiac problem and you operate him and everything is fine. No, you have a lot of other problems to face with. So, these are all the problems. Now I will give you some solutions for the problems. One is called anticipatory healthcare. Then we have a chronic care model, we have a cumulative complexity model, and we have the incremental medicine, and I will tell you what it is about. The anticipatory healthcare was invented by Julian Hart about more than 50 years ago, because he did a very interesting study, because he took two little towns, two villages in England, and the protagonists were doctors and nurses, and the one they did like they did always do, and the others made anticipatory healthcare. And what does it mean? That they phoned the patients. They didn't wait them to come up into their offices, because they said, oh, Mr. I don't know, Rossi, he has 30 pounds too much on his ribs and he will develop diabetes. So they phoned them and then come in and we will control your sugar level. Huh? Or somebody they knew he had a stroke and they called, because many people don't go to the doctor, and they called them in. And this was revolutionary. And you see that what did this much more than all the cholesterol drugs and diets and all these things. It was 28% less premature mortality. That's fantastic. But it didn't go into the world, how to say. Do you know a general practitioner who phones and asks if somebody did his blood sugar or somebody? No. If they don't come, they don't come. No, their fault.
I know.
You know? Or somebody?
In my village. No, that's true.
This is paradise.
No, that's true. That's true.
True, really.
We are trying to make a smart village with the general practitioner and the nurse.
Perfect.
And they are doing exactly that. But also using new technology like remote devices control.
That's what we can
so
today. Yeah.
This is facilitated now.
Yeah, yeah. So this is I would not, because the time is running already now. This is just to say what a chronic care model is. You see, it's quite difficult because you have the community, you have the health team, you have the informed, activated patient, if everything goes ideal, which meets a prepared and proactive practice team. This would be a paradise. So now I would ask you, these are two clearly obese people. What kind of diseases will they have? Obesity, it's a condition. What problems will they have? Diabetes. What else? Sorry? Heart disease. Heart disease. Cholesterol. And what about the bones? They need new hips, new knees, new everything. No? So they have a lot of conditions, and the beginning was the obesity. They normally have also obstructive sleep apnea. When they get older, they will have obstructive sleep apnea, diabetes, hypertension, problems moving because of arthrosis. And then when they get older, they will also have some problem with dementia. So you see, what the future of these still young people is very complex. And when you put this in the cumulative complexity model, you see how difficult it will be. I had a 75-year-old lady with some cognitive impairment. She was diabetic, she had to do insulin, she had to do a ventilator because she had not only a sleep apnea but also a COPD and had high CO2 levels in her blood. So she had to do the insulin, all the medications for hypertension, heart disease, and so on. She had to do the ventilator every night. She had to at a certain point, it was all too much, and she came to me. I said, today you go to the diabetologist. And she said, no. She said, no. I am 110 kilos, and that's fine for me. I don't have energy to change my habits. And sometimes you have to do some compromises, because we all would like very lean patients, but it's not the reality. And so if she says, I cannot, I have to say, okay, I can understand you. But let's do at least this and this and this, and so we find a compromise, no? So chronic care is also a lot of compromise, because you cannot do everything. This is a very interesting article. You can still get it. You get it also in Italian. This is the Italian one. You can have it also in the New Yorker. And this was of Atul Gawande. Somebody of you knows Atul Gawande? If you don't know him, this is a real world you can. He's a surgeon. He's a surgeon, and he said this. Because of the impossibility to change people and the difficulties to make them change their lives, and he was a young doctor, and he wanted to be a real doctor. He said, a real doctor, I would like to do something which really changes. And he chose to become a surgeon. And especially, he did this kind of article, and he said this about the incrementalists. And he made a very big change, because he said they focus on the course of a person's health over time, even through a life. All understanding is provision and subject to continual adjustments and compromises. For Rose, taking the long view meant thinking not just about her patient's bouts of facial swelling, or her headaches, or her depression, but about all of it, along with her living situation, her family history, her nutrition, her stress levels, and how they interrelated, and what that picture meant a doctor could do to improve their patient's long-term health and well-being throughout life. And his consequence of all this is that at the end, a general practitioner for the life in a long-term period can do more for the patient than a famous surgeon. And this is something we have to see also, that this is a real, very important work, and even more if they are really incrementalists and proactive physicians. So now I change to all another theme. This is what we had until now is our developed world. We have chronicity also in the developing world. And this, I made the example of India, where there are 1.34 billion people, and they have two big clusters of diseases. They have chronic diseases like diabetes, and they have still all the infectious diseases, like especially the diarrhea in very small children, and they have a lot of diabetes because Indian people, we don't know exactly why, with the lower weight, they have more abdominal fat, and they will develop diabetes earlier than we do here. So they have also a lot of cardiovascular problems. They have a lot of renal failure because of this. And these two things, they have to go together in India. And this is also very expensive, you can imagine. And on top of this, what happened in India? There came COVID. So the situation there was really very, very difficult. But in some things we could also learn from them, because they had faculties in the slums of India where they could bring under control certain situations we didn't have. But many people died in India from COVID, and we don't even know how many there are, because the political system there is what it is. Then we have this, just to be in our years now, we have a big epidemic in the pandemic, which is the long COVID epidemic. Millions of people are suffering from long COVID conditions, which is all this. What I see is especially cough and chest pains, but many suffer from lack of appetite, from diarrhea, from Sjögren's syndrome, which is an autoimmune disease. So this is still a work in progress, but we will have a lot of chronic problems because of COVID. Chronicity is a pandemic in the pandemic, no? But because we know that the people who died in the beginning, especially in Italy, but also in other countries from COVID, were the people with chronicities in the nursing homes, because there was the really big mistake to put the people with pneumonia from the hospital to the nursing homes, and there many of them died. Thinking chronic, and I invite you to think chronic, because it saves lives and money, and it reduces also your frustration in your work. You have to be, for this, anticipatory, incremental, creative. Be creative also with all the new methods and technologies we have. And we need a completely new organization of healthcare. This, I think, it's very clear. Now in Italy there are a lot of money also for the health system, but I don't see that they are on the right way for this. And just one thing about robots. And the question is, would you like the nice nurse or would you like this one? You know that in Japan there are a lot of nurses substituted by these kind of robots, and it's a very interesting way. And I think on long term we should have both of them, because we have not enough nurses. This is very, very easy. We don't have nurses. Nobody wants to become a nurse. Nobody wants to work in long-term facilities. So we have to do this. This is if you would like to know more about it. And now I would like to show you another video, which is completely different. It's a very, very long, perhaps the longest, I think you don't know it, the longest study ever done. It's 75 years old, and the study tries, no. This is really. No. No. Oh, no, See. Sorry, di tu qualcosa, io cerco il link.
Well, after this lesson, how many of you will become a general practitioner? Nobody? Well, I think it is simpler to save a life in an emergency room than to follow a patient during his life. But in any case, in your daily life as doctors, you will meet a lot of patients like that, who are fat, who are diabetics, who are depressed, who are hypertension, who are so and so. If you don't have a chronic vision of the patient, you run the risk of missing something.
This is, so I will, perhaps we can discuss about it later. It's a study about what makes a good life. And it's not only about diseases, it's more, no, but listen.
What keeps us healthy and happy as we go through life? If you were going to invest now in your future best self, where would you put your time and your energy? There was a recent survey of millennials asking them what their most important life goals were. And over 80% said that a major life goal for them was to get rich. And another 50% of those same young adults said that another major life goal was to become famous. And we're constantly told to lean into work, to push harder, and achieve more. We're given the impression that these are the things that we need to go after in order to have a good life. Pictures of entire lives, of the choices that people make and how those choices work out for them, those pictures are almost impossible to get. Most of what we know about human life, we know from asking people to remember the past. And as we know, hindsight is anything but 20/20. We forget vast amounts of what happens to us in life, and sometimes memory is downright creative. But what if we could watch entire lives as they unfold through time? What if we could study people from the time that they were teenagers all the way into old age to see what really keeps people happy and healthy? We did that. The Harvard study of adult development may be the longest study of adult life that's ever been done. For 75 years, we've tracked the lives of 724 men. Year after year, asking about their work, their home lives, their health, and of course asking all along the way without knowing how their life stories were going to turn out. Studies like this are exceedingly rare. Almost all projects of this kind fall apart within a decade because too many people drop out of the study, or funding for the research dries up, or the researchers get distracted or they die, and nobody moves the ball further down the field. But through a combination of luck and the persistence of several generations of researchers, this study has survived. About 60 of our original 724 men are still alive, still participating in the study, most of them in their 90s. And we are now beginning to study the more than 2,000 children of these men. And I'm the fourth director of the study. Since 1938, we've tracked the lives of two groups of men. The first group started in the study when they were sophomores at Harvard College. They all finished college during World War II, and then most went off to serve in the war. And the second group that we followed was a group of boys from Boston's poorest neighborhoods. Boys who were chosen for the study specifically because they were from some of the most troubled and disadvantaged families in Boston of the 1930s. Most lived in tenements, many without hot and cold running water. When they entered the study, all of these teenagers were interviewed, they were given medical exams, we went to their homes and we interviewed their parents. And then these teenagers grew up into adults who entered all walks of life. They became factory workers and lawyers and bricklayers ask us, why do you keep wanting to study me? My life just isn't that interesting. The Harvard man never asked that question. To get the clearest picture of these lives, we don't just send them questionnaires. We interview them in their living rooms. We get their medical records from their doctors. We draw their blood. We scan their brains. We talk to their children. We videotape them talking with their wives about their deepest concerns. And when, about a decade ago, we finally asked the wives if they would join us as members of the study, many of the women said, it's about time. So what have we learned? What are the lessons that come from the tens of thousands of pages of information that we generated on these names? Well, the lessons aren't about wealth or fame or working harder and harder. The clearest message that we get from this 75-year study is this: good relationships keep us happier and healthier. Period. We've learned three big lessons about relationships. The first is that social connections are really good for us, and that loneliness kills. It turns out that people who are more socially connected to family, to friends, to community, are happier, they're physically healthier, and they live longer than people who are less well connected. And the experience of loneliness turns out to be toxic. People who are more isolated than they want to be from others find that they are less happy, their health declines earlier in midlife, their brain functioning declines sooner, and they live shorter lives than people who are not lonely. And the sad fact is that at any given time, more than 1 in 5 Americans will report that they're lonely. And we know that you can be lonely in a crowd, and you can be lonely in a marriage. So the second big lesson that we learn is that it's not just the number of friends you have, and it's not whether or not you're in a committed relationship, but it's the quality of your close relationships that matters. It turns out that living in the midst of conflict is really bad for our health. High conflict marriages, for example, without much affection, turn out to be very bad for our health, perhaps worse than getting divorced. And living in the midst of good, warm relationships is protective. Once we have followed our men all the way into their 80s, we want to look back at them at midlife and to see if we could predict who's going to grow into a happy, healthy octogenarian and who wasn't. And when we gathered together everything we knew about them at age 50, it wasn't their middle-aged cholesterol levels that predicted how they were going to grow old. It was how satisfied they were in their relationships. The people who were the most satisfied in their relationships at age 50 were the healthiest at age 80. And good, close relationships seem to buffer us from some of the slings and arrows of getting old. Our most happily partnered men and women reported in their 80s that on the days when they had more physical pain, their moods stayed just as happy. But the people who were in unhappy relationships, on the days when they reported more physical pain, it was magnified by more emotional pain. And the third big lesson that we learned about relationships and our health is that good relationships don't just protect our bodies, they protect our brains. It turns out that being in a securely attached relationship to another person in your 80s is protective. That the people who are in relationships where they really feel that you count on the other person in times of need, those people's memories stay sharper longer. And the people in relationships where they feel they really can't count on the other one, those are the people who experience earlier memory decline. And those good relationships, they don't have to be smooth all the time. Some of our octogenarian couples could bicker with each other day in and day out. But as long as they felt that they could really count on the other one when it got tough, those arguments didn't take a toll on their memories. So, relationships are good for our health and well-being. This is wisdom that's as old as the hills. Why is this so hard to get and so easy to ignore? Well, we're human. What we really like is a quick fix, something we can get that'll make our lives good and keep them that way. Relationships are messy and they're complicated, and the hard work of tending to family and friends, it's not sexy or glamorous. It's also lifelong. It never ends. The people in our 75-year study who were the happiest in retirement were the people who had actively worked to replace workmates with new closes. Just like the millennials in that recent survey, many of our men, when they were starting out as young adults, really believed that fame and wealth and high achievement were what they needed to go after to have a good life. But over and over these 75 years, our study has shown that the people who fared the best were the people who leaned into relationships with family, with friends, with community. So what about you? Let's say you're 25, or you're 40, or you're 60. What might leaning into relationships even look like? Well, the possibilities are practically endless. It might be something as simple as replacing screen time with people time, or livening up a stale relationship by doing something new together, long walks or date nights, or reaching out to that family member who you haven't spoken to in years, because those all too common family feuds take a terrible toll on the people who hold the grudges. I'd like to close with a quote from Mark Twain. More than a century ago, he was looking back on his life, and he wrote this: there is a time, so brief is life, for bickerings, apologies, heartburnings, callings to account. There is only time for loving, and but an instant, so to speak, for that. The good life is built with good relationships. Thank you.
Ecco, vi sembrava come? Interessante? No? Cioè io volevo concludere con questo, perché poi... Ah, sorry, sometimes I mix up the languages. Sì. Yeah, I wanted... Anche in German? No? No. So, no, I wanted to conclude with this because this is not our task. We as physicians, we don't have to fix up the relationships of our patients. But we have to be aware that this is very, very, very important. And much more sometimes it's also for our lives, because sometimes physicians are completely in the work and they don't have time for relationships and for friends and for relatives and for other problems. And but keep in mind that the relationships and the real deep relationships and not the messy ones, and that they will protect us. And this is not a medical issue. It's just a human issue, a social issue, I don't know. But it's a chronicle issue. And I thank you.
So, thank you very much, Dagmar. So the take-home message is love, love, love. Okay.
Yes.
Thank you. The lesson is finished. Okay. Have a nice.
È bello questo, vero? Vero? Proprio